And today we have a very exciting webinar. As you know, we're doing 7 webinars this week, the WFIPP, about innovative products and therapies. And today we have the pleasure of welcoming Novuqare, who is going to explain all about their product. The product itself, I'm quite excited to hear what Jelle Akkerman, who is the commercial manager of Novuqare, and Merel Hilgersum, who's a physical therapist, what they have to tell us about Novuqare and demonstrate its use. Bladder diaries is, of course, the topic that we have, and we all know what bladder diaries mean, at least sitting in the car park very quickly, scribbling in pencil or in biro a few answers, and those days, I think, have long gone, and there are ways and means that are far better. And you're going to tell us all about your product. I would ask everybody please to mute their microphones. We'll do that otherwise as well. And can you please talk reasonably slowly, because there are many non-native English speakers. So having said that, the recording will be available later for those who can't join today. We have a big registration for today's webinar, but of course not everyone can join, but that will be made available later. So Jelle, the floor is yours. Thank you.
Thank you, Lynn, for this introduction. And everybody, welcome. I'm very pleased that we can speak here today and introduce not only the company Novuqare, but also the Maple product, our innovative product for pelvic floor dysfunction diagnosis and treatment. And we are very pleased that we could speak here today to discuss the ongoing subject of sustainable continence and how Maple has a benefit on sustainability and how we can improve the future for the globe for future generations. So again, let me introduce myself. My name is Jelle Akkerman. I'm from the Netherlands, and I'm commercial manager at Novuqare. I'm here today with Merel Hilgersum, a pelvic floor therapist who has been working with the product for 7 years. 7 years, so quite extensive and very experienced. And as a bonus, we also have an interview with a patient who has been treated and is ongoingly with Maple, and you can hear from firsthand the experience with the product. If you have any questions, please put them in the chat box and we will reply to them. If we look at Maple, then I think first of all, it's important to list what Maple actually does. So the Maple device measures EMG within the pelvic floor. And EMG, myoelectrical activity generated by muscle fibers. When you measure EMG, it's very important to know 3 aspects. So the nerve who's actually sending signals to the muscle to generate the myoelectrical activity, the composition of the muscle, because the myoelectrical activity travels between over the length of the muscle fibers through a muscle. And furthermore, you need to know, because you need to know the composition, the length of the muscle fibers, you need to place the electrodes in length of the muscle to be able to correctly measure EMG within the muscle. Someone is speaking. Sorry. Thank you. EMG has been measured within for many years, for dozens, for decades, and the most common practice to measure EMG within pelvic floor has been via the bipolar probes, bipolar measuring, as you can see here.
Can you please mute yourself, whoever's speaking?
So the bipolar probes, you see a few examples here. They measure EMG in a bipolar method, and that method is used in medical professions and medical tasks. So, and it is actually a very effective way to measure a muscle. And in this case, this is a very easy representation of what it actually does. So you have the black box is actually the muscle, the red arrows are the muscle fibers, and you see that the arrows point in both directions through the length of the muscle. And then you have electrode A and electrode B on either side, and you measure the signals between those 2 points. So with 2 electrodes, you have 1 EMG signal, and it's actually a very effective way to measure a single muscle validly. If you look at the bipolar measuring techniques used in the pelvic floor, you actually see something very interesting, because these are the type of probes that are used. So plate electrodes, like here, you have 2 plates on either side, and you have ring electrodes that have rings that goes 360 around on different depths. And you have them in all sorts and sizes. And if you look at the autonomy of the pelvic floor, and you have to measure in this setup with these type of probes, you actually see something very strange. What you are actually doing is this. So you're actually measuring different muscles, different sites. You cannot identify where the electrode, in terms of a plate electrode or ring electrode, makes contact with which muscle. And you cannot compare the 2 EMG signals in such a way. And what you're actually doing with bipolar measuring technique, measuring pelvic floor muscles, is a non-valid measuring technique, because you don't know which electrode is located where and which signal you are comparing to which signal. It's, if I use a metaphor, it's like placing an electrode on my left arm, an electrode on my right arm, and then saying something about the function of either arm. It doesn't work that way. And this is actually the reason Maple was developed, because we wanted to create a system that was capable of validly measuring pelvic floor muscles. And that's actually why Maple was developed. And this is the Maple probe. And you see, if you compare it to these type of probes, it looks very different. So we have in total 24 individual electrodes on a single probe on 4 sides and 6 different depths. And we don't use a bipolar measuring technique. We use a unipolar measuring technique, where we actually have a reference electrode that's placed outside of the body on either the hip bone, the kneecap, or the elbow, at least a place where it makes good contact with the nerve system. We use that to measure the zero point of the body. And then we have the probe that you just saw with 24 electrodes that's inserted. And they use a unipolar measuring technique on each of the individual 24 in total points. So if you do a measurement with Maple, you have 24 active individual EMG signals simultaneously within the pelvic floor region. Now, we have tested this technique in countless clinical studies. One of which I would highlight is the healthy volunteer study. There are a number of other studies. And by the way, clinical study is still ongoing with Maple. We not only do studies ourselves, but we also support a lot of clinical studies abroad and in the Netherlands, like UK, Germany, the Netherlands, Belgium, and some other examples. If we look at the healthy volunteer study, this is a study that we actually used to prove the reliability and validity of the Maple system. And in total, we tested 250 healthy volunteers who did not have any issue with their pelvic floors. At the end of the study, we could use the data of 229 healthy volunteers. Sadly, during a study, some volunteers always leave the study or cannot continue. These were divided into one group male and a number of group female. We had a standardized protocol to do the measurements, and we recorded the EMG values per individual electrode per patient. So per patient, 24 individual EMG signals per measurement. We tested the reliability of the signals, and we did a verification of the location of the probe within the body by placing some patients under an MRI scanner. And these are some examples here. So the two top images are male. The left front view, the right is side view, and the bottom pictures are female. Left front view, right side view. And here you see in a very good and clear manner how the probe is located within the body and where the electrode actually makes contact with the nearest muscle. So that's the EMG signal it is measuring. Now, because we did this study and because we proved the location of the probe within the body, we were able to create a visual representation of the probe and how you should analyze the data that actually comes from the measurement. And we did that what we call the grid, and this is a tunnel view of the pelvic floor. That has been a 3D image that has been made flattened into a 2D image, divided into 4 different regions: anterior, posterior, left, and right. And each section is divided into 6 individual squares, and each of those sections is an individual electrode. If you look at the probe and how that represents in representation to the probe, it's like this. So really go from the outside all the way inside. And because we have this very clear representation of the pelvic floor and the EMG activity within the pelvic floor, it's very easy to distinguish some of the muscle groups within the pelvic floor. So this is during a vaginal measurement, and this is during an anal measurement. If you work with Maple in practice, this is the image you will see. So the top right image, of course, is just an example, but the left image is how you would work with the system in practice. So on the right side, on the left side, you have the grid, and you see in the gray colors, you see how much activity there is. And the activity goes from white is no EMG activity, and very dark is a high EMG activity. And then on the right side, you have the line graph. And the line graph shows the average EMG signal of all active electrodes. So in this case, 24. And it shows the average signal to show the contraction or how high the signal actually is. And this is a quick video of how you what the options are. So this is a rest measurement of a patient. Now here we will start. You first see the peak, and that's the system starting up. And this is actually a rest measurement, so the patient should relax. And then you can see very clearly the activity within the pelvic floor. And see there's a little more on the right side, there's more activity than on the left side. Maple, maybe you can also tell us something about this image.
Yeah, well, you've seen before the image with muscle activity. And as you can see in the fourth quadrant on the right, you can see darker colors. So this is referred to the puborectalis muscle. So now we know during resting, the puborectalis muscle is overactive. So there's more activity in this muscle. A resting measurement takes about 1 minute, and then we can see all activity. With a vaginal measurement, it should be between 0 and 2. And with an anal measurement, it should be between 0 and 4. So now the measurement is done. And now we know the puborectalis muscle is on the right side, more active during rest. And now we can make it even clearer to deactivate all the electrodes that are not overactive. And then we're going to just see the activity of the puborectalis muscle. Now we can see a resting measurement of just the puborectalis muscle. And as you can see, the average in the top area is higher than before. And as you look at the line graph, you can see the line is also higher up. So now we know exactly how high the resting activity is of the puborectalis muscle. And we have a good 0 point for our treatment, because we want to get back between 0 and 2 or 0 and 4, depending on which type of measuring you're doing. And this is a vaginal measurement, so we want to be in between 0 and 2.
Thank you.
You're welcome.
So this is just a quick example of how you would use the system in practice, and how you could use the system to really analyze and go in depth into diagnosis for the patient, and then treat the patient the treatment is very targeted to the issue for the patient. Well, if you then come to the real, of course, the real subject of today, sustainable continence care, and then ask ourselves, okay, how does Maple actually benefit sustainable continence? Well, Maple is able to diagnose and treat the patient much more targeted and much faster than any other system on the market. And because we are able to diagnose the patient in such high definition and to treat the issues the patient has so specifically, we are able to decrease treatment time, but also decrease incontinence materials that the patient may need in their day-to-day life. One of the examples is incontinence materials that are used around the world, like pads, for example. And if we even have a slight decline in pads used by treating people and patients with Maple, we have a huge impact on not only the environment, but also on their quality of life, resulting in huge public health cost savings and also huge climate impacts, because these pads have a huge impact on the climate. And some pads, because they are made of plastic, even have a decompose time of up to 400 years. And they are just thrown away into a landslide or a landfill. Well, you already saw her speaking earlier. So Merel, maybe you can
Yes,
take it up from here.
I will introduce myself. So my name is Merel Hilgersson. I'm a pelvic floor therapist for 7 years now. I work at the Profundum Institution in the Netherlands, in Dordrecht. I also teach for the Profundum Academy, and I'm a teacher at Advanced Plus, the Master Pelvic Floor Therapy, and I'm an ultrasound teacher and tech, of course. I started working with the Maple 7 years ago, and I'm giving trainings with the Maple for 2 years now. So I work at the Profundum Institution. This institution is founded by Marijke Schiekert ten Hove. She's one of the godmothers of pelvic floor therapy in the Netherlands. And since 2011, we have our own pelvic floor center. We're one of the largest specialized institutes of the Netherlands, and we take care of complex patient care. We're not only seeing patients from the Netherlands, but also from Belgium, Germany, France. They all come in to see our patient care. So I started with Maple when it was released on the Dutch market. Marijke got one of the first systems, and she was not quite handy with the iPad, so she gave it to me, and I started working with it, and I got really experienced working with Maple. And I really enjoyed the benefits of the Unipolar Pro, because now I could make a specific diagnosis of a specific muscle. I really got to learn how the grid works and what you're seeing. And I had a good understanding of the physics behind the EMS. So if you all have this in your own toolbox, you can really do great diagnosis, but also limited your treatment sessions. So I think when I started working with Maple, my average treatment session went down by 50%, I think. I don't know for sure because I never really measured, but it got way less, way less treatments. So today we're going to introduce Mr. Jack, and Mr. Jack is a Parkinson's patient. And just to give you some background, urinary incontinence and Parkinson's disease are, really high prevalence in the Netherlands. So in 2018, there were 52,200 patients with Parkinson's disease in the Netherlands. And they often experience lower tract symptoms. So we call this LUTs. And if you look at the numbers, if you go to urge incontinence, it's in between 21 and 40% in those 52,200 patients. So quite a lot of Parkinson patients experience problems with the bladder and, the urinary tract and incontinence. So this, should be better treated. But Parkinson isn't a disease that can be treated because it is progressive. And also due to the medication the patients take to get rid of some of the symptoms, the bladder gets affected. So, with the maple, we cannot treat, of course, the complete disease, but we can sustain the incontinence so they don't get their complications they normally have. But they need to come back. So it's a maintenance program. So then we go to Mr. Jack. This is a male patient of mine. He is 71 years old. He is diagnosed with Parkinson's disease for 12 years ago, and he now experiences urinary incontinence for 10 years. And due to the urinary incontinence, he has a less quality of life. But he came in and we started doing a maple treatment and we can maintain his continence. So he has a better quality of life. And now I want to introduce you to the story of Mr. Jack.
Nou, welkom. Dankjewel. Leuk dat je wilt meewerken aan dit interview over het gebruik van de maple in de behandeling van het urineverlies. Ben benieuwd. Ja, ik ook. Ik wil graag een aantal vragen stellen. Allereerst, we weten dat u Parkinsonziekte heeft. Hoe lang bent u daarvoor mee bekend? Toen ik 58 was, ben ik 72 bezig. Deze verschijnselen zich voor. Dat is dansles, dat is weer schaatsen, dat is weer skiën. En op een gegeven moment ga je dan toch een keertje naar je huisarts. Die verwijst je door naar de logopedist, naar de fysiotherapie. Nee, die voelt zich nog veel te sterk. Dat is geen Parkinson. Uiteindelijk, 1,5 jaar later, kom je nog een beetje terug. En dan kreeg je een proces van 2-3 maanden en is dat gewoon bekeken. En is duidelijk van, het is Parkinson, maar waarschijnlijk zal het zich heel langzaam voltrekken. Dat is eigenlijk het punt van waar ik toch in 2010, 2 jaar nadat ik de eerste verschijnselen zelf opmerkte. Vanaf die tijd gaat het heel geleidelijk aan. Stapje voor stapje gaat het gewoon terug. Ik was eerst bang dat het veel sneller zou gaan, maar het valt niet mee. Het valt niet te leven. Dat is in ieder geval heel erg fijn. En welke klachten ervaart u allemaal van de Parkinson? De ernstigste klachten zijn dat je helemaal te zwak haast bent om uit bed te stappen. Dat je gewoon een 10 ton voelt die op gang gebracht moet worden met een heel klein motortje. Wat ik ook heel lastig vind is dat je dan moet gaan bewegen. Er zijn altijd, vooral zijn het klachten van fysieke aard. Het gewoon niet kunnen bewegen, niet kunnen opstaan. Maar op het moment dat je die pillen inneemt en dan verstrijkt er zijn 20 tot 40 minuten, dan word je op een gegeven moment niet meer liggen. Ja, dat is wel heel fijn dat dat in ieder geval op de markt is. Ja. En ik ben bekend met urineverlies. Wanneer is dat probleem ontstaan? Weet u dat nog? Ja, ik denk dat dat gewoon in ontstond in de beginfase van, de eerste 2 jaar van dat ik het Parkinson kreeg. En die ongewild urineverlies, dat hing dan weer samen met dat je niet goed uitgeplast had. Of dat je plotseling overvallen werd in de kou. En dat je eigenlijk geen gelegenheid zag om eventjes gewoon te gaan plassen ergens. En dan doet het bij een boom en je doet op een gegeven moment de struikjes.
Totdat je bij wijze van spreken door een dame op leeftijd of kinderen van tieners uitgejouwd, uitgezet wordt voor vuile viezerik. En dat je dan denkt van, stiekem weer allemaal ja, ik ga niet meer op stap.
Nee, dat kan ik me heel goed begrijpen. En dat is ook echt enorm vervelend en levensbeperkend ook wel. En ik denk dat het mentaal ook zeker wat doet.
Jazeker. Je blijft langer, je stelt een bezoek aan de stad, maar even op weg gaan, stel je gewoon uit. Of corona kwam nu bijvoorbeeld heel mooi uit, maar in die eerste fase natuurlijk gewoon helemaal niet. Je werkte gewoon van, je steeds meer een huis gebonden en je sociale omgeving werd steeds goed kleiner. Ik zeg altijd, vroeger in mijn werk liep ik constant met de telefoon in mijn hand en nu gaat het niet meer.
Wat voor werk heeft u vroeger gedaan?
Ik was directeur van de basisschool.
Dat is ook een heel mooi beroep.
Ja. Ik heb 42 jaar in het onderwijs gewerkt als leerkracht, als schooldirecteur van de school. En dat was op een gegeven moment toch gewoon in 2013 afgelopen.
Was dat ook door de Parkinson?
De onderliggende reden, denk ik, dat ik dat achteraf zo wel moet stellen. Het was meer gewoon zeg maar, vanuit mijn omgeving dat er signaal kwam van stel verstandig dat je dit blijft doen enzovoort. Die voelde dan toch een soort als een druk van buitenaf die naar het uitgaan leidt.
Ja, maar als ik het zo hoor, dan heeft Parkinson heel veel invloed op uw leven gehad. Altijd heel sportief ook geweest, heel bewegelijk. Hoe gaat dat nu?
Ik ben iemand die gelukkig aardigheid heeft in bewegen. Dat heb ik altijd gehad. En ik heb in de loop van de jaren gewoon diverse apparaten op mijn zolder verzameld. Van loopband tot een crosstraining, tot een roeier, een stepper. En daarnaast probeer ik gewoon ook zoveel mogelijk te wandelen of wat te fietsen buiten. Een hele misschien grappige ervaring is, dat ik nog helemaal niet genoeg is het zwemmen. Ik was vroeger als kind en later ook echt een waterrat. En ik sta ergens in 2012, 2013 en je zwemt in Zuid-Frankrijk. En ik duik erin en ik voel, ik kom weer aan de overkant.
Oh, dat is een gekke gewaarwording.
Ja, ik redde het gewoon niet met het zwemmen. En later constateerde ik dat je wel, als je rustig bent, dat je normaal aan die overkant komt. Je hebt geen kracht meer in je slag. Dus je komt haast niet vooruit. En omdat de ene hand beter beweegt dan de andere hand, ga je ook nog een keer linksaf of een rondjes draaien.
Oh, dat is wel heel confronterend dan, denk ik.
Ja.
Ja. Gaat dat nu wel beter?
Nee.
Nee, oké. Nee. Nou ja, en u bent toen op een gegeven moment voor het urineverlies ook bij de uroloog beland.
Ja, nou nog eens via de uroloog. Ik had ongewild urineverlies en ik maakte dat bekend bij mijn huisarts.
Oh ja.
En mijn huisarts was onder de behandeling geweest van Marijke na een prostaatoperatie. En hij sprak er heel lovend over. En heb ik ook zoiets van, het hoeft nog niet het einde te betekenen van het leuke leven.
Nee, want toen bent u aan de slag gegaan met de TENS.
Ja, toen ben ik Marijke. En aanvankelijk had ik ook het idee van, nou dat is wel, dat leidt tot succes. En op een bepaald moment, op de een of andere manier bouw je dat wat af. Dan heb je er soms wat minder last van. En dan denk je gewoon misschien het is het. En dan na een poos zie je gewoon de verschijnselen komen weer terug.
Ja.
En zodoende ben ik toen zeg maar, via de uroloog bij je terechtgekomen.
Ja, en toen bent u bij mij onder behandeling gestart.
Ja.
En toen zijn we eigenlijk met de maple begonnen onder het mom van laten we kijken of het nog wat kan verbeteren.
Ja.
Is het toen verbeterd?
Ja.
En wat zijn verbeteringen die u toen merkte?
Als je in elk geval de plas wat iets langer kon ophouden, dan kon je erop instellen, gewoon van het stukje fietsen van de woonplaats naar de plek waar jullie je praktijk hebben. Dan kon ik zo inschatten, dat duurt ongeveer zo lang, dat moet ik dan lukken. En als dat ook 2 keer lukt, heb je iets meer zelfvertrouwen dan dat de derde keer misgaat. Het gaat allemaal op en neer, maar
Ja, en in het begin hebben we best wel frequent behandeld. Hè. Toen kwam we bijna wekelijks, denk ik wel, bij mij.
We starten met een hogere frequentie en die
Ja.
frequentie is op dit moment wat minder.
Merkt u dan ook dat de klachten wat sneller terugkomen of blijft dat wel stabiel?
Het is soms lastig, want ik was langer op vakantie. En in die
Ja.
vakantie was mijn leven natuurlijk gewoon wat anders, 6, 7 weken. En dan loop je veel te wandelen langs het strand of in het bos.
Ja.
En dan moet je eigenlijk zeggen, ik kan pas als ik nou weer een paar keer terug geweest ben in deze tijd, dan kijken van, hey, zitten verschillen.
Ja, en dat merkt u nu dan wel?
Ja, maar tot nu toe moet je gewoon vaststellen, lukt het om, ik denk mede dankzij de behandeling, om de plas op te houden en ja, te wachten, eventjes de tijd hebben tot je in het moment hebt dat je de wc kan.
Nou, dat is wel ontzettend fijn.
Ja, in dit verband denk ik dat het ook nog goed is om te zeggen. Als je in Spanje bijvoorbeeld bent,
Ja?
je loopt daar een winkel binnen, of het nou een kledingzaak is of een kruidenierszaak. Direct bij de ingang hebben ze een prachtig toilet.
Ja, dat is wel heel fijn.
En dat zijn dingen die bij wijze van spreken in Hoogland totaal mist.
Ja. Ik denk dat daar nog steeds wel heel veel winst op zou kunnen behalen als er meer openbare toiletten zijn. Want we weten sowieso dat er in Nederland heel veel Parkinson-patiënten zijn en dat het probleem met urineverlies enorm hoog is. Ja. Mede ook de startstijfheid, het niet kunnen halen, soms niet kunnen wegkomen wanneer je wil, maar ook het hele neurologische probleem omheen op de continentie. Dus het zou fijn zijn als er voor die mensen, maar ook alle andere mensen met urineverlies of gewoon plasproblemen, meer toegankelijkheid zou zijn voor de wc's. Heeft u het idee dat de behandeling met de maple de kwaliteit van uw leven weer wat beter heeft gemaakt?
Ja. Ik moet zeggen van, ik zou wensen dat het voor 100% opgelost zou zijn.
Dat
het lijkt soms net alsof je gewoon behandeld wordt, gaat het weer wat beter en dan lijkt het net weer of het wat afzakt.
Ja, ik denk dat dat ook wel komt door het hele ziektebeeld van de Parkinson. De Parkinson wordt natuurlijk steeds, de progressieve ziekte wordt steeds slechter, dus je vecht tegen tijd.
Ja, ik heb erg moeten wennen aan alle dingen die je met Parkinson hebt. Vandaag ben je soepel en morgen ben je weer, kan je zeggen, van misschien zelfs zo stijf als eergisteren.
Ja.
Het gaat iets beter en dan gaat het weer wat minder.
Het is echt wat op en af, hè?
Ja, maar ook is zo met deze behandeling van zijn maple.
Maple, ja.
Nou, dat geeft zeg maar een stoot in de goede richting. Daar teer je eventjes op en dan zakt het gewoon weer wat terug. Dus het is niet iets van, althans bij mij als Parkinson, dat je zegt van nou, het is opgelost.
Nee.
Het is opgelost voor het moment tot het weer terugkeert.
Ja, ja, en dat is wel iets wat je echt bij Parkinson ziet, dat het meer een product is waarbij we de klacht weten te onderhouden, maar we kunnen hem niet oplossen. Maar doordat we hem kunnen onderhouden, kunnen de mensen wel weer meer in het dagelijks leven. Ja. En dat is denk ik het allerbelangrijkste, dat je weer een beetje vertrouwen in je eigen lijf krijgt. En ook weer op uit durft te gaan.
Zeker.
Want ik weet wel dat u ook graag fietst en dat u veel onderweg bent.
Ja.
En ja, dan is het wel heel vervelend als je gehinderd wordt door dit soort problematiek.
Je zou wensen dat het gewoon echt overal voorbij zou zijn.
Ja.
En ik ben ook blij met wat de behandeling biedt. Maar het is niet iets wat zeg maar voor 100% dekkend is.
Nee. Het zou mooi zijn als we dat nog krijgen.
Ja.
Gaan we ons best voor doen.
Dank je.
Ik wil u enorm bedanken voor dit gesprek. En dat u dit met de wereld wilde delen. Ik denk dat het hele waardevolle informatie is. En ja, nogmaals bedankt.
Graag gedaan.
Nou wel.
Oh. Well, this was the story of Mr. Jack. He's very glad with the treatment of the maple. He now gets out and can go to his hometown and well, doesn't have to worry about urinary incontinence. It's not over, but with the treatment we can maintain. So I made some of the benefits for the patient viewable. So there's more awareness and understanding of the pelvic floor due to the biofeedback of the maple. In some cases, no surgery is needed. You need less treatment sessions than before. You can make a detailed diagnosis of the muscle dysfunction. It's a very small probe, so you can even use it if the patient has vaginismus. Sorry. It's usable vaginal and anal, and for all types of incontinence. So you can use for urinary incontinence, fecal incontinence, but also for incontinence of flatus. And you can treat several dysfunction in one session. Quite for an example, you can treat the overactivity, but you can also treat muscle function in one session. And of course, less use of incontinence materials. So the benefits for the insurance companies, well, of course, less treatment sessions, less cost for operations, less cost for incontinence materials, and the maple treatment is supported by the Dutch Ministry of Health. And then, of course, benefits for me as a therapist. I can make a detailed diagnosis. I can use one probe for vaginal or anal. It's a small probe, so it fits all. I have less treatment sessions, more awareness for my patients, and I can use it for all types of dysfunctions. And I can even use it for complex multi-dysfunction cases. And of course, the most important fact, I have a happy patient. So thank you. And I see that we have some questions in the chat box.
Okay, oh, perfect. Let me see what they are. So the first one is, how much does the probe cost? Well, the probe costs, it depends per region due to the sales tax, of course, but roughly between from us to the market, it depends, but you should expect between the 60 and 90 euros, depending on which market we're in. How much does a program cost? So it's the program itself is it's a single patient multiple use probe. So the patient has an individual probe, and they can use that probe for the duration of their treatment. So in that case, 60 till 90 euros for the patient in case they don't have to pay for the therapy sessions individually. For the product itself, for the maple system, that depends also on the region, between the 6,000 and 8,000 euros, depending. Hi, Susie. Are you based? We have a distributor in the UK, Susie, indeed. Yes. Pioneer Medic.
That's me.
Yes.
Okay, that's great. Thank you. I haven't used your product before, so it's good to know you have an English, because I'm based in England. It's good to know you have an English-based supplier, yes. And that probe sounds pretty reasonable if it's single patient but multi-use, so that it's only they'll use one probe for their entire sessions. Exactly. That's pretty good, really. Yeah, great. Thank you.
Okay, you're welcome. Are there any other questions? Well,
yes, I'm this Lynn. I'll come up with a question. I don't know what's happening with. Hang on, you're stopping the screen sharing. Let's see. Yeah. First of all, some of the practicalities. We're talking about the Netherlands here. We've been talking at length about a Parkinson patient. Perhaps.
Hi, how are you?
Perhaps you could maybe elaborate on what your future plans are, where you're going with this, and what kind of healthcare professional patient you're aiming at in a very broad sense. I think people would want to hear that from you.
Yeah, I fully understand that. So what we are aiming at is to properly diagnose and targetedly treat pelvic floor dysfunction. And we are trying to find the best way to do that per region. So in the Netherlands, we really focus on pelvic floor therapists, because in the Netherlands, as a Dutch citizen, you have a direct line to a pelvic floor therapist. You can visit them because it's part of our base insurance. In other countries, we are focused more on the urologist side, because they need to diagnose, or in some cases also treat the patient. And then in other regions, it's incontinence nurses, for example, or some other profession that is part of their infrastructure to treat this kind of dysfunctions. So it really depends on the market we're in and where the patient goes to have their pelvic floor treated and diagnosed. In terms of our company's view, we are continuously improving the product. And we do that mainly due to software updates. We try to really listen to our customers, what they need, and improve the product in that sense. So add more functionality to diagnose and treat the patient.
Okay, and another question perhaps.
Perché hanno adesso il mio nome tutto, che io ho messo tutto su.
Sorry. Yeah, can I? Since we're talking about these days a lot on self-care and self-management, what about a home application? Is that on the cards? Can you please mute whoever's... Yeah, thanks. Can you please mute whoever's not speaking? Thank you.
So we are of course also developing new products or additional products. We are currently having a prototype of a home device, which we are developing, but due to current market conditions, I cannot give any clarity on when we will be able to launch the products. So there, and we also are focusing more on the hospital market in the future, to having a more of a hospital or clinical system. In terms of, because I did not bring that up yet, so at this point we are mainly focused on the European markets and on a number of Asian markets and Middle East. But we are in the process of FDA approval, and we are hoping that we will have that within the coming months.
I think FDA approval would be very much to be desired. Let's put it that way. That's one thing. There's a question here about, is the NHS a customer of yours?
So we have some, but perhaps Susie, do you?
Hi, okay.
Yeah, hi Susie. Yeah.
Hi. They are not, it's not listed on the NHS as in listed on the supply chain. So you'd have to buy it off the supply chain, which is not normally a problem. We've only, as Yeli knows, we've only just taken over the distribution in the UK. I think that, is that from you, Suzanne? The question, yes, it is. So yeah, so we are the distributor for the Maple device here in the UK, and happy to get back to you with prices, etc., because I know that you've asked about that. But the NHS is something that we will look at, but obviously we have to wait until it comes onto the contract is rolled out for us to be able to go on to contract. So it's something that we will look at. I hope that answers your question.
Just maybe because we have pelvic floor therapists who are using this, and the profundum, we know, here in the Netherlands, and in other countries, urologists or HCPs. Is there, or to what extent do they work together? And it's probably a stupid question, but I'll put it there anyway.
Well, it's we see there's a high variety in that case. So it can depend per country, but it also can depend per hospital. We have a number of hospitals, and I think Miro can support this. Is that we have a number of urologists who really send in patients to a pelvic floor therapist for diagnosis and treatment before they take any action. But we also have urologists who don't even ask and just do their thing and get on from there. So it depends highly on the own, also on the views of the patients or the urologists themselves.
Yeah, and I can also say that the proctology in the Netherlands, in case of flatus incontinence or fecal incontinence, sends in directly to our institution for diagnosis with the MAPLE. So the proctologists know what the grid says and what the line graph says. So we do the measurements and then we send our information back to them so they can do their treatment, of course, better because they know what the pelvic floor does.
This, I think, is probably the way forward, and what we would call true collaboration in terms of diagnosis. It's obviously something to be worked on, and probably yeah, we can maybe help with that as well, that kind of thing.
Always good to hear.
Yeli, somebody is asking a question about
Yeah.
biofeedback. They've asked, can it stimulate the muscles to reduce high pressures?
Well, it can stimulate for overactivity. I think that's probably what, I don't know who's asking, of course, who the person is asking, but you can directly stimulate on every specific muscle the MAPLE is referred to due to the muscle composition. So if you look at the video imaging we saw before, there was an overactivity of the puborectalis muscle. And then if I start working with EMS, I can directly stimulate the puborectalis muscle to decrease the tone or the activity, not the tone. We decrease the activity and that will give less tone. Is that what you were asking?
It's not me asking. Hopefully that has answered the question.
When you said that you can reduce the session time by 50%, what are we talking about? Just to have some indication of what patients can expect.
Yeah, it also depends, of course, on the nerve activity in the pelvic floor. So if there's nerve damage, it will take longer. But I think with urinary incontinence, my treatments are up to 4 sessions and then they're completely gone out of their urinary incontinence. So normally I would take about 8 to 10 sessions, I think, and now I take up 3 to 4, so it reduces quite a bit. And then I make a combination of the EMG, the biofeedback, and the EMS to treat.
Thank you. Yes, another question again about shared decision making with patients, about the idea and the notion of a home application and training, etc., because it's not just Parkinson, there's MS and some of the other.
What is the question exactly?
About this notion about the shared decision making with patients. Will there once be, I'll read verbatim, will there once ever be a home application as a possibility for training and treatment for patients with chronic diseases like Parkinson and MS? That was the question.
Okay, that was the question. We are focused on that in the development of the MAPLE line. So we are really in development. We are focusing on a home product, and that home product then in turn can be used for all type of disorders, including for the example patient we have had today, Mr. Jack, who is a Parkinson's patient and therefore also suffers from incontinence problem.
I think from the patient perspective, if like you said, you 4 sessions and then you're dry, let's put it very bluntly, I think many patients would jump at the opportunity if it were available.
Yeah, I think so as well. But that's when it's about normal stress urinary incontinence of or urge incontinence. But with Parkinson, I maintain. So the patient keeps coming back.
Okay.
And the average is higher. Due to the medication, the urinary incontinence will keep on going. And with the maple, we can maintain his continence. So he has less incontinence materials, he has better quality of life, he can go out more, but he needs to get back for treatment. So that's, well, he would like it to be 100% over, which I can understand, but I cannot cure Parkinson's disease, but I can maintain his continence.
No, I think, again, someone else is saying about this notion of, do people have to come to a clinic, or can they be treated at home as well? I think that's a huge market that as yet needs to be developed from what I gather.
I do think that because we know that there are a number of home products on the market. What we know from our experience with maple is that a diagnosis to have a correct treatment is very important. That's also why currently maple is only available for the medical specialist able to diagnose and therefore treat a patient. Our home device will also be in that line, that we are focused on how can we treat the patient and targetedly treat the patient. For example, what we see for many home devices is that they are used by patient at home without actually knowing what the issue is. They have a pelvic floor dysfunction, they know that, and they start a treatment that can also have a adverse effect for them, because, for example, if they already have an overactivity and they start training, their problems will only get worse.
Yeah, we see this a lot.
Yeah, and therefore, a good diagnosis is key to have a good treatment.
I think this idea of the diagnostics, very much so. If we look very often at the average time it takes to diagnosis, it can very often be years, as we know, and that's not acceptable in this day and age. Again, someone else is saying, when we're talking about Mr. Jack, we could hardly see Mr. Jack, but we could see the subtitles, so that was okay. But what was exactly the diagnosis and treatment, Meryl? Someone's asking that specifically.
He came in with urge incontinence, and that was what I was treating. And I find this case a good example for sustainable health, because if we didn't do the maple treatment, he would use way more incontinence material, he wouldn't get out, he has a worse quality of life. And due to the maple, he can go out again and he has quality of life and he uses less incontinence material. So for the nature, well, and for him, for everything, it's better. But he was treated by urge incontinence.
Okay. Again, I think in this home setting, there's a lot of questions about that, but the need for actual training and supervision, because you can't just have a device unless you know what to do with the device and how to use it. That's
sorry. Well, I think from my professional point of view, you need to have a diagnosis to start treating.
Yes.
Because we get patients in who are very enthusiastic and then go on internet, buy a training device, have overactive pelvic floor, and then come in with worse incontinence.
Yeah.
And the overactivity is way worse. So I think it would be good to have a home device, but first you need your diagnosis and you need to know which training session you need to do at home. So you can make it better and not worse. So it would be great for patients to do it at home, but I think diagnosis is necessary.
Absolutely, and we need centres of excellence like yours, of course, to pave the way for that. I agree. The notion, this week is concentrated on the idea of sustainable continence care, and I love the idea of reducing this massive amount of waste that's produced by absorbents and the likes and the microplastics, etc. It's a pet bugbear of mine. I'm hoping that we'll very slowly do something about it, and not so much. I mean, we're talking about Western Europe, but we're talking about globally, the rest of the world. It's huge with landfill and the like. So I think we all have to work towards that. Well, I think you've given us a very good indication of what Novuqare means, and I think there'll be quite a lot of interest generated by what you've said today. The presentations, if that's okay, will be made available together with the recording for the 150 people or so who registered for today's session. And I would like to thank you and thank Novuqare very much for this webinar, and everybody for listening and watching, and bye-bye. Thank you.
Thank you.
Thank you.
Have a good day.
Thank you.